So without further ado, I think we'll launch into it. Dr. Faruqi will be coming in as our first speaker, and he'll be talking about big data and AI techniques in cataract, where we are, and we'll carry it on from there. The introduction. So the introduction comes from Dr. Naik sir. Sir, introduction to आपसे होता है. Dr. Naik himself needs no introduction, the past president and the legendary editor IGO, the man who started, the father of Indian research methodology. And he's one of the thinkers who likes to make things simple, lucid, and easy to understand. So he's the best person to be talking about complicated and complex issues like artificial intelligence. So he'll be giving us an introduction to it, and then we'll carry it on from there.
So I'm going to just give a short introduction about big data and artificial intelligence in ophthalmology. Now in this there are two keywords. No, one is a big data, and this term was coined in 1990s, includes large quantities and diverse types of data, which probably it's unimaginable. We cannot imagine that what type of big data that now we are going to have. And it became possible due to super fast computers. And the other thing is artificial intelligence. Now this term emerged even earlier. And the first academic conference on AI occurred in 1956. The concept of computer was existing before World War II, and this could happen because of artificial intelligence, because of computers and the phenomenal growth of computers. And I remember in about 1960s, sometimes they were talking there will be 2 supercomputers which will be sufficient for the whole world. And now you can imagine even some of the people who carry mobile phones, they are also like supercomputers. And the golden years of AI, 1956 to 76, the question of whether a computer can think is no more interesting than the question of whether a submarine can swim. The successful marriage of big data and AI has been one of the greatest steps forward in medical research this century, because earlier whatever was limited, it was just in a small group or a small focused subject or focused area. But now these concepts became revolutionary, diverse drivers of medical research of late. The electronic, and this could happen because of 2 things. One was electronic health records and medical imaging data, because medical imaging data is huge, which is already there existing. And because of this, the multi-omics, where the multiple omics, which is phenomics, metabolomics, proteomics, means all kinds of omics can be combined together, which earlier it was not possible without this artificial intelligence. Started solving challenging medical research questions, and because of that, now we are talking about personalized medicine. In ophthalmology, fortunately, and we should be taking pride, is in forefront of AI, and because of machine learning and deep learning, due to ubiquitous availability of non-invasive, rapid and relatively inexpensive ophthalmic imaging compared to the other discipline. The Intelligent Research in Sight, IRIS registry, is the largest clinical database in the world, led by AAO. The big data and artificial intelligence research are data-driven rather than observation to hypothesis approach, which was earlier the approach was, and allows discoveries outside the boundaries of traditional research methodology. That's why I said now it's multi-omics can be, because all in one place it can be combined. And like certain development or certain discoveries done, novel biomarkers in the midst of multi-omics data sets, the subtle associations which was not possible with smaller data sets, and identification of some imaging features which again was possible because of AI. Now the hyperreflective outer retinal band associated with delayed rod-mediated dark adaptation, an established marker of early ARMD, which could not have been possible without AI and big data. This process drives generation of new hypotheses and better insight into disease mechanism. Now there are certain means associations with already, but these associations need to be tested. Now, progression of glaucoma and pulmonary function, deep learning algorithm to detect drusen, neovascular ARMD, diabetic macular edema, creating OCTA from structural OCT image alone. So, can you imagine? Just you give that machine, that artificial intelligence, the OCT image, and they will tell you about they will create OCTA image, the forecasting future field defects from a single baseline visual fields. Now, this is something which is unimaginable, and probably if this comes, then we can diagnose all glaucoma patients, which patient is going to be worsen, and we can be more aggressive in treatment. The open source quantification of oculoplastic measurements using routine facial photograph, just one photograph, and it will tell you all measurements. So, but there are limitations. So, don't think the picture is always very rosy. Statistical and clinical significance, there are two different things which one has to understand. Understanding data to train AI algorithm, that which data has been provided to train this data algorithm. Based on that, you will get the outcome. The validation of big data and AI study results in independent study cohorts. So you got that finding, but then you have to study in a special cohort so that you know what is the applicability and EHR data validity, because this EHR is so huge that whatever data is put in is really valid data which are being done. And challenges are standardization of data sets, data sharing processes, data privacy, ethical issues, and transferring research findings to clinical use. And so AI can be used for diagnostics, drug development, personalized treatment, and gene editing. And it's a rapidly evolving field. Future is bright, and 30 years down the line, the medical science would have changed unimaginable, which is unimaginable now. And you will definitely ask questions, will AI replace doctors? Whatever answer I give now, probably all those young minds who are present here, they will only testify after 30 years the answer whether it can replace doctors or not. Thank you very much.
Thank you so much, sir. And the IRIS started off in 2014 as that was the first database. It is a registry. It's a clinical registry where all the doctors, the retinal surgeons, they started uploading their data, and then we had something called FRB which came up, which collated data from different continents. And the IRIS actually gave us very interesting insights. It showed us that we were talking about anti-VEGFs being offered, and they found that a very small fraction, hardly about 20% were being offered anti-VEGFs in their visits. And when it was used, it was not ranibizumab which they had been propagating in all their conferences, but it was Avastin was very common. And there were a lot of real world examples of how the world was behaving, and what we were talking in conferences was very different. What was there in the journals was very different. So this real world data, when we started integrating that actually gave us so one small question. We've always been talking of technology taking over the functions. Would it leave us with more time, or would it improve our quality of life as physicians, or should we be really afraid that there would be job losses? So